Hello, my name is Yejun Hong. I'm a medical student in the University of Calgary, and our team is here to discuss cataracts, which is one of the most important ophthalmic presentations. A cataract is an opacification of the crystalline lens that affects vision. A lens is a structure made of tissues, but it also needs to be of a consistent protein structure to maintain a constant refraction index. This has to converge the light very delicately in a way that the light converges exactly on the retina, on the surface of the retina. And this protein must also be clear enough to prevent any scattering of light. The opacification of the cataract will refract the light very abnormally such that it scatters inside the eye. There are various etiology that's associated with the development of cataract, both congenital and acquired. The crystalline lens resembles a common onion. It is comprised of many different layers with gradual changes in the refractive index in a way that a light can progress through it in a very natural manner. The crystalline lens is composed of the lens nucleus and the surrounding cortex and the capsule that surrounds all of that. And on the surface, it is lined with its own epithelial cells. The crystalline lens is held by the zonular fibers, which in turn are held by the ciliary body of the anterior uvea. These muscles can pull or relax against the lens through the zonular fibers, which alters its shape. This is how we can accommodate to objects that are close to us and also stretch the lens thinner when we're looking at distant objects. Congenital opacity of the lens can be categorized by location. Capsular cataract is when the lens capsule has been affected, usually on the anterior side of the lens. The lamellar or the zonular location involves the central and the circumscribed areas around the nucleus. The polar regions are the central opacity near the anterior or the posterior capsule. These are like the polar sides of the Earth. And that analogy is very similar in a way that the equator is in a similar relative position to the polars in the lens as well. The sutural location would appear as a Y-shaped opacity at the location of the sutures, the natural sutures on the lens. The acquired cataract can also be categorized by location. First, the cortex can degenerate around the nucleus, which will result in swelling and liquefaction of the fiber cells within the lens. That will appear as spokes and vacuoles, and these will be very asymmetrical and radial spoke-like, and they'll be linear and may include punctate dots as well. Mature cataracts will be completely opacified and will give no red reflex when you shine the ophthalmoscope light into the eye. Orgagnian cataract is mature and dense nucleus inferiorly in a completely liquefied white cortex. The nucleus is displaced inferiorly because the cortex beneath it can no longer support it because it has turned liquidy from solid. Hypermature cataract is the stage after the Morgagnian, and the lens as a whole shrinks and the capsule that surrounds the cortex wrinkles. because the liquefied cortex eventually dries and leaks out, and the calcium deposits on the lens as well. The second acquired cataract is the nuclear sclerosis. The nucleus itself can sclerose and cause central lens discoloration. The opacity often appears yellow-green or brunescent hue, and this is caused by the deterioration of the central lens fiber cells. The last acquired cataract we will look at is the subcapsular cataract. The anterior subcapsular involves the central fibrous plaque right under the anterior lens capsule. And a posterior subcapsular is the asymmetric granular opacity with the frosted glass appearance at the posterior surface of the lens. An infant has a higher risk of developing a congenital cataract if there is a family history of cataracts, and if the baby is found to have chromosomal abnormalities such as Down syndrome, which is famous for presenting with snowflake cataracts, or also Turner's. Any craniofacial abnormalities, CNS impairments, and dermatological syndromes can also lead to congenital cataract. And intrauterine infections while in the womb, like rubella and varicella, can result in a cataract, unfortunately. Some metabolic syndromes, such as the galactosemia, Alport syndrome, hypoglycemia, hypocalcemia, and Fabry's disease, can raise the risk for cataract as well. In terms of ocular disorders, any persistent hyperplastic primary vitreous, Leber's congenital amaurosis, retinopathy of prematurity, aniridia, or asymmetric size of the pupils, and posterior lenticonus can contribute to the risk. Risk factors for acquired cataracts may include age-related lens changes, systemic diseases like diabetes, hypocalcemia, and myotonic dystrophy, which characteristically presents with Christmas tree cataracts. Others may include Fabry's disease, atopic dermatitis, neurofibromatosis type 2, as well as ectodermal dysplasia. These three cataracts comprise of the 99% of the acquired cataract, and there are criteria for diagnosing each of them. For nuclear sclerosing, trace or 1+ is for when the nucleus appears clearer than the surrounding anterior and posterior sections. 2+ is for nucleus with the same level of opacity with the surrounding. 3+ if the nucleus is denser, and 4+ is for brunescent or completely opaque or brown. Cortical spoken cataract would be evaluated as 1+ if the cataract involves 1/8 to 1/4 of the radial area. 2+ if the radial angle covers 1/4 to 1/2 the area, and 3+ if the area covers half or more. For cortical spoken cataract, think of the pieces of a pizza. Posterior subcapsular cataract would be 1+ if the vertical height is 1 to 2 millimeters, 2+ if 2 to 3 millimeters, and 3+ if it's more than 3 millimeters measured. Symptoms of a cataract would include the decreased visual acuity and glare, especially at night with the light ahead. This is because the uneven refractive index with the opacity of the lens completely scatters the light as the light enters the eye. And rarely, monocular diplopia may also occur for the same reason. Some signs of cataract includes decreased visual acuity, leukocoria, which is a white reflex instead of a red reflex, amblyopia, nystagmus, and decreased contrast sensitivity. Focal and diffuse lens opacification will also be observed in instances of cataract. The complications of cataract include iris bowing forward and blocking the trabecular meshwork, leading to secondary angle closure glaucoma. Hypermature cataracts may also leak lens proteins and lead to phacolytic glaucoma. And to prevent these complications, cataract surgery to remove the crystalline lens is warranted. And these will be shown in the following slide. And here. So these are probes going into the anterior chamber and performing capsulorhexis. There is a very vast differential diagnosis considering how many syndromes can concurrently cause cataracts. And as we've covered before, there are also many conditions that raise the risk of cataracts. So take some time, feel free to pause the video and read through all the conditions that we talked about. These are just a continuation of the potential differential diagnosis that you should consider. When seeing a patient with cataract, a thorough ophthalmic history is warranted. Pay attention to any family history of eye disease, any recent trauma, maternal illness, or usage of drug during pregnancy and birth complications, as well as any systemic diseases, any medical conditions. Those will be important and prudent questions to ask. Measure the visual acuity, do a thorough slit lamp exam, as well as try to look at the fundus as well, but this is not the most important thing for a cataract appointment. To perform tonometry and gonioscopy for potential complications for advanced cataracts. Some lab work for investigating cataracts include the B-scan ultrasound if the fundus is not visible because of the opacity of the lens. Keratometry and biometry can be used to calculate IOL implant power that must be determined before putting it into the eye in cataract surgery to perform a torch titer. Order it to see if there are any infections causing the cataract, fasting blood sugar for diabetes, urine reducing substance after milk feeding for galactosemia, order calcium for hypocalcemia, and urine amino acids for Lowe's syndrome. Treatment of cataract includes dilation using tropicamide 1% with the optional phenylephrine addition 2.5% before surgery to dilate the pupil as much as possible for a good view of the lens. This also helps the light to go around the central opacity as well. Do not delay this cataract surgery in infants because they still need their visual axis to mature, and if the cataract obscures this axis, amblyopia can develop. Patching or occlusion therapy with atropine can be done if the amblyopia is already developed. And if the cataract is unilateral, patients may require muscle surgery after the cataract surgery to correct the strabismus. Remove milk from diets for less than age 4 for any galactosemia. Cataract extraction and insertion of IOL can be done if the visual symptoms interfere with daily activities and the patient desires any improved visual functions. The prognosis of cataract is very good, and 96% and above is the success rate of the cataract surgery. The surgery is also considered very short, taking around 10 to 20 minutes, and it is very safe as well. For congenital cataracts, it depends on the age and the duration of a visually significant cataract. The prognosis of their vision is poor if amblyopia already exists. This is a depiction of a cataract surgery. They are dividing the crystalline lens so that it is easier for the probe to break it down and absorb it. This is a summary chart of everything we talked about. Feel free to use this for reference later. These are the sources of information from which we got the information to put together this PowerPoint.